Welcome. Welcome to the session of General Anesthetics. I'm Dr. Jayababu, Assistant Professor, Kamakati Medical College, Warangal. By the end of this session of General Anesthetics, the medical MBBS student, phase 2, should be able to know the objectives, should be able to define what is general anesthesia, explain the stages of general anesthesia, should be able to know the mechanism of action, classify the general anesthetics. You should know the properties of the ideal general anesthetics, explain the pharmacokinetics of general anesthetics, describe pharmacological actions and adverse effects of general anesthetics, enumerate the complications and the important drug interactions with general anesthetics. You should know what is pre-anesthetic medication and the rational use of drugs for the pre-anesthetic medication, the balanced anesthesia, compare and contrast the nitrous oxide, the halothane, enumerate intravenous anesthetic agents. By the end of the session, the MBBS phase 2 medical student should be able to know all these objectives. Salutes to our great Maharshi Sushruta, who belongs to 600 BCE, an ancient Indian physician. He is considered as the father of surgery. His textbook Sushruta Samhita has 184 chapters, described 1120 illnesses, 700 medicinal plants, and 64 mineral preparations. He did many procedures such as incisions, probing, surgery for hemorrhoids and fistulae, as well as cataract surgery. He is also known as father of plastic surgery. His contributions include in the fields of physiology, embryology, and immunity. Sushruta is the pioneer of 300 different types of operations, and he described 125 surgical instruments, including the endoscope. Our salutes to the great person, or Maharshi Sushruta. Coming to the history of general anesthesia, the nitrous oxide was discovered by Priestley in 1776, but it was used for the first time in 1846 by Horace Wells, a dentist in Hartford, USA, for a painless tooth extraction. And Morton, a second-year medical student, in 1846, successfully showed the use of ether as a general anesthetic in the first classic demonstration held in the operating room of Massachusetts General Hospital, Boston, USA. Since then, anesthesiology has progressed considerably, and many safer agents are now available for use. Definition of the general anesthetics. General anesthetics are the agents which bring about a loss of all modalities of sensation, particularly pain, inhibition of autonomic reflexes, relaxation of skeletal muscle, amnesia, and a reversible loss of consciousness. General anesthetics are the agents which bring about a loss of all modalities of sensation, particularly pain, inhibition of autonomic reflexes, relaxation of skeletal muscle, amnesia, and a reversible loss of consciousness. So general anesthesia characteristics. A good general anesthetic should think about unconsciousness, which is reversible, analgesia, amnesia, muscle relaxation, loss of reflexes, and immobility. So there is no single anesthetic that can produce all the above effects. Hence, the anesthetic protocol includes pre-anesthetic medication, induction of anesthesia, maintenance of anesthesia, and skeletal muscle relaxation. And also, analgesia is produced as a medication, pre-anesthetic medication during the operation and also after the operation. The general anesthetics are rapid CNS depressants and act by depressing synaptic transmission, produce quick induction and recovery, then hypnotics and sedatives. The techniques for methods of administration of inhalational general anesthetics. We have open method, the simple method of administering the volatile anesthetic, a simple mask like a skimmel busk mask, which does not fit the contour of the face, is held on the face, and an anesthetic such as ether is poured on in drops. The anesthetic vapor, diluted with air, is inhaled through the gap between the mask and the face. The method does not need any anesthetic apparatus. There is no rebreathing. This is also called as open drop method. Semi-open method. This method is similar to an open method, but the dilution with air is prevented by using either a well-fitting mask, such as Oxton's mask, or layers of gas between the face and the mask. A small carbon dioxide buildup occurs with this method. Semi-closed method. This method allows some rebreathing of the anesthetic drug with the help of the reservoir. A part of volume of each succeeding inspiration is the new portion from the anesthetic mixture. This method involves accumulation and rebreathing of carbon dioxide. Closed method. This method employs the chemical agent soda lime to absorb the carbon dioxide present in the expired air. It requires the use of special apparatus, but it is particularly useful when the anesthetic agent is potentially explosive. Stages of anesthesia. Gödel in 1920, referring mainly to the anesthetic ether, outlined the 4 stages of general anesthesia and divided the third stage of surgical anesthesia into 4 planes. The stages can be distinctly discerned with the majority of the volatile general anesthetics. The stages are as follows. Stage 1 is the stage of analgesia. This stage stretches from the beginning of the inhalation of anesthetic to the loss of consciousness. It is manifested as a sensation of remoteness, falling, suffocation, or as a visual or auditory aberrations. A feeling of warmth is experienced by some individuals. Analgesia is produced in the stage before the loss of consciousness. Minor surgical procedures such as incision of an abscess, dental extraction, obstetric maneuvers can be carried out successfully during this stage 1. It is difficult to maintain it for a long time. In the later stage 1, amnesia is observed. The patient rapidly loses consciousness to pass into stage 2, the stage of delirium. Stage 2 is also the stage of delirium or excitement. Stage 2 extends from the loss of consciousness to the beginning of surgical anesthesia. It may be associated with excitement, shouting, increased muscular activity, breath holding, tachypnea, and hyperventilation. Some of these manifestations are due to release of lower centers from the inhibitory control of higher centers as a result of cortical depression. The pupils may dilate and marked hypertension and tachycardia may develop due to release of adrenaline. Struggling, increased tone of skeletal muscles, retching, and vomiting are the undesirable features of this stage. They can be minimized by proper pre-anesthetic medication and rapidly increasing concentrations of anesthetic agents. Stage 3 is the stage of surgical anesthesia. This stage is characterized by regular respiration, a gradual loss of reflexes, and a relaxation of the skeletal muscles. Reflex activities lost. This stage is usually employed for surgical intervention, and this stage is divided again into plane 1, plane 2, plane 3, and plane 4. In plane 1 of the surgical anesthesia, that is stage 3 anesthesia. In plane 1, the pupils dilate progressively with the depth of anesthesia. The respiration is full, regular, deep, and of thoraco-abdominal in character. The blood pressure and the pulse rate are normal. The skeletal muscles are incompletely relaxed. The lid reflex, swallowing, retching, and vomiting get abolished. The corneal reflex is present, but the conjunctile reflex is lost. The loss of pharyngeal reflex in the middle of this plane enables the anesthesiologist to pass a pharyngeal airway. Plane 2, the respiratory exertions are regular, but the amplitude is diminished. Muscle relaxation is adequate. Reflexes arising from the larynx are also abolished, and the endotracheal intubation can be performed. Plane 3, this is characterized by beginning of asynchrony between the thoracic and the abdominal respiratory movements. The blood pressure begins to fall and the intercostal muscles are gradually paralyzed, and the respiration assumes an increasingly abdominal character. The pupillary light reflex and the corneal reflex are lost. The muscle relaxation is essentially complete. Plane 4 of surgical anesthesia. Plane 4, the paralysis of intercostal muscles is complete. The pupils are dilated and do not respond to the light. The muscles are flaccid. The blood pressure is low. The secretions are completely abolished. Stage 4, that is stage 4 is stage of respiratory paralysis. This stage is characterized by severe depression of the vital medullary centers, leading to vasomotor collapse and the respiratory arrest. Circulatory and respiratory support is must. The stages described may differ considerably with the different anesthetic agents. So coming to the mechanism of action of the general anesthetics. The mechanism of action, although the general anesthetics are capable of depressing all the functional elements of the CNS, including the spinal cord, their clinical effects may vary depending on their chemical structure and their ability to localize within the central nervous system and interact with the target sites. Specific cortical areas exhibit different sensitivities to the inhalational and intravenous anesthetics. Molecular targets for anesthetic agents are primarily proteins of the neuronal ligand-gated ion channels. The molecular targets for anesthetic agents are primarily proteins of the neuronal ligand-gated ion channels. The major channels associated with nicotinic receptors, 5-HT3, GABA-A, and NMDA receptors are the binding sites for the anesthetic agents. So the binding sites for the anesthetic agents are nicotinic receptors, 5-HT3 receptors, GABA-A receptors, NMDA receptors. The specific receptors vary from anesthetic to anesthetic. For example, nicotinic receptors and NMDA receptors for nitrous oxide, nicotinic receptors and NMDA receptors for nitrous oxide, GABA-A for IV anesthetics, GABA-A receptors for IV anesthetics, intravenous anesthetics, NMDA receptors for ketamine. In general, these agents inhibit the release of presynaptic excitatory neurotransmitters. The general anesthetics inhibit the release of presynaptic excitatory neurotransmitters. General anesthetics also alter the postsynaptic responsiveness to the released neurotransmitter and also by enhancing the inhibitory neurotransmission within the CNS. So general anesthetics inhibit the release of presynaptic excitatory neurotransmitters, alter the postsynaptic responsiveness to the released neurotransmitters by enhancing the inhibitory neurotransmission within the CNS. Though the speed, the induction, the factors which control the transfer of inhalation anesthetic agent from the alveoli to the blood and from there into the brain follows its solubility in blood, the factors which control the transfer of inhalation anesthetics from alveolar to blood, from blood to the brain, depends on solubility, its solubility in blood, its density. The lighter the gas, the faster does it diffuse into the and out of tissues. Its partial pressure in the anesthetic mixture, that is solubility in blood, is inversely proportional to the partial pressure in the arterial and mixed venous blood and in the tissues. Solubility, density, partial pressure, and the rate of blood flow through the lungs and tissues. Factors involved for the transfer of general anesthetics from alveoli to the blood, blood to the brain, solubility, density, partial pressure, and the rate of blood flow. The lower the solubility of the anesthetic agent in the blood, the more rapid is the rise in the partial pressure in the arterial blood. The lower the solubility, the more rapid in the rise of the partial pressure. For example, nitrous oxide, desflurane, sevoflurane have low blood solubility, but they are rapidly reach the high arterial tensions. This leads to rapid equilibrium with the brain producing rapid induction. The highly soluble anesthetic agents with high blood gas partition, the highly soluble anesthetic agents with high blood gas partition coefficient, such as diethyl ether, show slow induction, slow recovery, and slow change in the depth of anesthesia. So the lower the solubility of anesthetic agent, more the more rapid in the rise in the partial pressure. Example, nitrous oxide, desflurane, sevoflurane. The highly soluble anesthetic agents with high blood gas partition coefficient like ether shows slow induction, slow recovery. The higher the concentration of anesthetic agent in the inspired gas mixture, the greater will be the rise in the partial pressure in the blood. The higher the concentration, the greater will be in the partial pressure of that inspired gas mixture. Higher the rate and depth of ventilation, the rise in partial pressure of anesthetic agents will be higher. The lower the solubility, the higher the partial pressure. The higher the concentration, the greater will be the rise in the partial pressure. The higher the rate and depth of ventilation, there is a higher in the partial pressure and high blood solubility. The general anesthetics have low margin of safety and therapeutic indices vary from 2 to 4. It is also difficult to estimate the dose accurately. The anesthesiologist describe the measure of potency of any inhalational anesthetic agents in terms of minimum alveolar concentration, MAC. Minimum alveolar concentration of the anesthetic at 1 atm pressure that produces ablation of movement in response to surgical incision. Usually 0.5 to 2 Mach is required for adequate anesthesia. So minimum alveolar concentration is the minimum concentration of the anesthetic in the alveoli required to produce immobility in response to painful stimulus in 50% patients. It indicates the potency of inhalational general anesthetics. So there is a transfer of anesthetic agent from alveoli to blood and blood to brain. Depth of anesthesia depend upon minimum alveolar concentration and partition pressure. Classification. General anesthetics are divided into inhalational anesthetics and parenteral anesthetics or intravenous anesthetics. In inhalational anesthetics, we have gas, that is nitrous oxide, and volatile liquids. We have ether, halothane, enfluorine, isoflurane, desflurane, sevoflurane. Coming to the parenteral or intravenous anesthetics, we have inducing agent drugs like thiopentone, propofol, etomidate, and slow-acting drugs like benzodiazepines. Then we have diazepam, lorazepam, midazolam, ketamine is another slow-acting drug, parenteral in general anesthetics. We also have opioids like fentanyl, alfentanil, sifentanil, remifentanil, acting as a slow-acting general anesthetics. Inhalational anesthetics. In this, we have nitrous oxide, also called as laughing gas. Nitrous oxide is a colorless inorganic gas with sweet taste. It does not undergo significant decomposition in the body. Nitrous oxide, if administered along with the air, produces a stage of excitement and delirium and also produces amnesia, hence the name laughing gas. It is commonly used together with oxygen and other agents such as isoflurane. Nitrous oxide produces analgesia when inhaled in the concentration of 35% to 40% with air. Loss of consciousness occurs with a concentration of 65% to 75%, and the plain one of surgical anesthesia can be reached with an 80-20 mixture of nitrous oxide and oxygen. A further increase in the concentration of the anesthetic agent produces hypoxia. Nitrous oxide has no serious deleterious effects on circulation, respiration, the liver, and the kidneys, and is probably the safest anesthetic agent. Nitrous oxide is not altered within the body and is carried out in the form of physical solution in the blood. It is rapidly eliminated through lungs within 2 to 5 minutes after its withdrawal. Advantages: nitrous oxide is non-inflammable and non-irritant, rapid induction and recovery, Analgesic in subanesthetic concentration, nausea and vomiting are uncommon. Disadvantages of the nitrous oxide: it is not a potent anesthetic agent by itself, must be supplemented with another pre-anesthetic agent or a muscle relaxant. Excitement may be violent. Carbon dioxide accumulation and hypoxia may develop during prolonged use. Diffusion hypoxia develops at the time of discontinuation of nitrous oxide and is dangerous in the patient with low cardiopulmonary reserve, which can be prevented by the administration of 100% oxygen while discontinuing the nitrous oxide. A special apparatus is required. An increase in the spontaneous abortions has been reported in the wives of male dentists and in female chairside dentist assistants. Any closed gas-filled space tends to extend during the administration of nitrous oxide, therefore contraindicated in patient with the collection of air in the pleural, pericardial or peritoneal cavities. Nitrous oxide may cause hallucinations. Female patients might allege sexual misbehavior by the doctor, as hallucinations may occur with the nitrous oxide. Female patients might make allegations of the sexual misbehavior by the doctor. Therapeutic use of the nitrous oxide: it is used for the tooth extraction, obstetric analgesia, and during painful procedures such as changing dressings in burns patients, cleaning and debridement of wounds, and cauterization. Coming to the volatile liquids, the general anesthetics divided into inhalational. In inhalational general anesthetics, we have gas and also volatile liquids. The gas, we have nitrous oxide, and in volatile liquids, we have ether, halothane, enflurane, isoflurane, tesoflurane, sevoflurane. Coming to ether is a colorless volatile liquid with a pungent odor. Anesthetic ether contains 96 to 98% diethyl ether. Ether vapor is irritating. Ether, when exposed to air, moisture, or light, may form ether peroxides, acetic aldehyde, which are irritants. To avoid this conversion, ether is marketed in sealed containers or amber-colored bottles covered with black paper. So ether, when exposed to air, moisture, or light, may form ether peroxide or acetic aldehyde, which are irritants. To avoid this conversion, ether is marketed in sealed containers or amber-colored bottles covered with black paper. Ether is inflammable, and mixtures of ether with air, nitrous oxide, or oxygen may explode over the entire range of anesthetically useful concentrations. A concentration of 10% to 15% of ether is in the inspired air is usually required for induction. while the concentration of 4% to 5% ensures satisfactory maintenance of anesthesia in plane 3. Ether rubbed into the skin produces local vasodilation with a sense of warmth and pain, that is rubefacient action. Ether dissolves the sebaceous secretion, and in the form of ethereal soap, it is used as a cleansing agent. Ether is also used as a solvent. Only a minor portion of ether is oxidized within the body. 85% to 90% is eliminated through the lungs. Advantages: ether can be administered without complicated apparatus, can be used during an emergency without pre-anesthetic medication, has wide margin of safety, excellent analgesic, can be used during delivery, and it's economical. Disadvantages: it is inflammable, explosive, induction is slow, and irritant, may cause convulsions, especially in children. Halothane, it's a fluorinated volatile anesthetic. It's a heavy, colorless liquid with a characteristic sweet, fruity odor. Halothane produces loss of consciousness in the concentration of 2% to 3% in oxygen vapor, and the anesthesia is maintained by using 1% to 2% of the halothane vapor with oxygen and nitrous oxide. About 60% to 80% of halothane is eliminated unchanged to the lungs in the first 24 hours. Advantages: non-inflammable, non-irritant, potent anesthetic, inhibits pharyngeal and laryngeal reflexes, making the tracheal intubation easy. Can induce controlled hypotension and bloodless field. Disadvantages: special apparatus is required, poor analgesic, inadequate muscular relaxation, depresses respiration. Coming to the enflurane, halogenated volatile liquid anesthetic, non-inflammable, with sweet odor. Anesthesia produced by enflurane resembles closely to the one produced by the halothane, except that the muscular relaxation is better and tachypnea is uncommon. It is widely used except in neurosurgery. Isoflurane, the volatile liquid with pungent odor. Its pharmacological action similar to the halothane. Advantages: stable and non-inflammable, rapid induction and recovery. It's a bronchodilator, good muscle relaxant, potent coronary vasodilator. Isoflurane is considered by many as a near ideal anesthetics, the preferred agent in neurosurgery. This fluorine, The properties are similar to that of isoflurane. Extremely volatile with pungent odor, rapid onset of action, and rapid recovery. It may cause cough, salivation, and bronchospasm. This fluorine, hence it is not preferred for induction of anesthesia. Sevoflurane is a non-irritating to the respiratory tract, can be used for the induction of anesthesia in children, and it is pleasant to inhale. Coming to the parenteral or the intravenous anesthetics. In this, we have inducing agents, thiopentol, propofol, etomidate, and slow-acting drugs like benzodiazepines, opiates, and ketamine. Coming to thiopentol, it's a ultra short-acting barbiturate, most commonly used for induction. Given intravenously, it rapidly induces hypoxia and anesthesia without analgesia. The induction is very quick and pleasant. Consciousness is lost first, then the reflex activity and muscle tone, and lastly, the vital medullary centers are depressed. Pupils react to light and remain contracted in the light hypnosis. The corneal reflex remains active until deep anesthesia. It also reduces cerebral metabolism. Cerebral blood flow and cerebral metabolic rates are reduced. And there is marked reduction in intracranial tension. It's a choice for the patients with cerebral swelling. A fairly reliable sign of an adequate induction by thiopentol is the absence of eyelid reflex. The presence of swallowing, phonation, and reflex movements of the eye during anesthesia indicates a need for further injection. Although the reflexes return in 10 to 30 minutes after stoppage, the patient remains disoriented for several hours and must not be left alone. The very short duration of action is attributed to its high lipid solubility. The rapid metabolism of the drug by the liver may also contribute to its short duration of action. With successive doses, body fat depots get saturated with the drug. Slow release of the stored drug back into the plasma is responsible for the prolonged recovery and continuation of drowsiness observed after the cessation of anesthesia. Advantages: non-explosive, non-irritant, very rapid and smooth induction, and rapid recovery after small doses. Disadvantage: poor analgesic. Conducting anesthesia and judging its depths are difficult as the usual stages of anesthesia are not discernible. Depression of the respiratory center. The barbiturate anesthesia is used with great caution in the presence of hepatic or renal damage, or in the shock, or in the airway obstruction, or in individuals with past history of bronchial asthma and cardiovascular diseases. Thiopentol is used for the induction of general anesthesia as an anesthetic agent for operations for short durations, that is fracture reduction, dilatation and curettage, laryngoscopy, bronchoscopy. Methoxytone preferred during electroconvulsive therapy as it increases ictal activity. Methoxytone is preferred during electroconvulsive therapy as it increases ictal activity. Thiopentol is used as anesthetic in patients with a history of malignant hyperthermia, head injury, and brain tumor. Thiopentol is used as an anticonvulsant in emergency treatments of intractable seizures. Etomidate is similar to thiopentol, faster induction and recovery. May cause involuntary movements during induction and recovery. Propofol, the intravenous or parenteral anesthetic, causes rapid induction and rapid recovery with a small hangover effect. It is generally used for sedation, induction, and maintenance of general anesthesia and for brief ambulatory procedures. It causes dose-dependent cortical depression and it is an anticonvulsant. Advantage of propofol as a specific antiemetic action, quick and pleasant recovery from anesthesia. It is used for intubation in endoscopy and daycare surgery. Propofol is safe during pregnancy. Disadvantages: narrow therapeutic window. Prolonged IV infusion can lead to accumulation with sedation and acidosis, results in propofol infusion syndrome seen in patients with head injury. Fast propofol, a water-soluble prodrug, is claimed to cause less pain on IV injection. It is hydrolyzed by endothelial alkaline phosphatase to propofol. Ketamine, this agent is chemically related to phencyclidine and acts as an antagonist at NMDA receptors. Ketamine probably acts at the cerebral cortex, particularly in the limbic system. Ketamine has an analgesic property, and light anesthesia usually does not cause depression of the protective pharyngeal and laryngeal reflexes. Ketamine is a potent bronchodilator. Given intravenously, ketamine is quick in action. Following a single dose of ketamine, it induces a state of dissociative anesthesia characterized by complete analgesia combined with amnesia and catatonia. With or without loss of consciousness, the patient can open his eyes and can obey instructions. Respirator support is not needed. Analgesia lasts for about 40 minutes, whereas anesthesia lasts about for 15 minutes due to rapid redistribution. Anesthesia by ketamine can be induced by both intramuscular and intravenous routes. A low dose of 0.1 to 0.25 mg per kg intravenous produce adequate analgesia. However, ketamine should be avoided in the patients with the ischemic heart disease. Disadvantages of ketamine: causes delirium, hallucinations, and colorful dreams during induction and recovery, especially in adults. Diazepam, midazolam, propofol given prior to the ketamine can prevent these disturbances? It is a drug of abuse, also called as date rape drug. It can be ketamine can be used as an inducing agent. It is a choice in poor risk elderly children and patients with asthma. Ketamine is used for short lasting diagnostic procedures such as cardiac catheterization and bronchoscopy, dressing of bones, forceps delivery, breech extraction, manual removal of placenta, and dental work. Ketamine should not be used in patients suffering from hyperventilation or cerebrovascular accident. Should not be used for surgeries of pharynx, larynx, and bronchi. Should not be used in thyrotoxicosis patients. Midazolam, it's a benzodiazepine, slow onset of action and recovery. It's a slow acting drug. Used as a preoperative sedation for procedure like endoscopy. So, general anesthetics refers to a drug-induced reversible loss of consciousness and all sensations. The features of general anesthesia are reversible loss of consciousness, reversible loss of sensation, analgesia, amnesia, muscle relaxation, and abolition of reflexes. There is no single anesthetic agent that can produce all these effects. Hence, the anesthetic protocol includes pre-anesthetic medication, induction of anesthesia with either with, for example, thiopentone and propofol, maintenance of anesthesia with nitrous oxide and isoflurane or nitrous oxide and halothane, skeletal muscle relaxation, analgesia as a pre-anesthetic medication during the surgery and after the operation. The use of other drugs like to reverse the neuromuscular blockade, to reverse the residual effects of opioids and benzodiazepines. We have balanced anesthesia, both IV and inhaled anesthetics are used. In modern anesthetic practice, the stages are never listened separately because of the combination of agents. This balanced anesthesia is used. Usually, a rapid and smooth induction is achieved with the help of an intravenous agent such as thiopentol or propofol. The anesthesia is maintained with the inhalational drugs such as halothane or nitrous oxide, oxygen, plus a volatile anesthetic such as isoflurane. Such combinations are termed as a balanced anesthesia techniques, which utilize optimally favorable properties of anesthetic agents, minimizing their adverse effects. Conscious sedation. We have IV anesthetics with local anesthetics. Conscious sedation technique employs the use of small doses of intravenous anesthetics such as propofol and midazolam along with opioid analgesics to produce pain and anxiety-free altered level of consciousness. In this state, no respiratory support is needed and the patient can respond to commands. This technique can be used in ICU for patients under stress and on mechanical ventilators by using additional agents such as muscle relaxants and dexmedetomidine. The dissociative anesthesia that is produced by ketamine. When ketamine given intravenously, it is quick acting. After the following of single dose, it induces a state of dissociative anesthesia characterized by complete analgesia combined with amnesia and catatonia with or without loss of consciousness. The patient can open his eyes and can obey instructions. The respiratory support is not needed. Analgesia lasts for about 40 minutes, whereas anesthesia lasts for about 15 minutes due to rapid redistribution in dissociative anesthesia. Neuroleptic analgesia. The neuroleptics are the antipsychotics, are the group of the drugs which induce a state of apathy and mental detachment in which the patient is mildly sedated and uncaring about his or her surroundings. These compounds are used in the treatment of major psychosis. Neuroleptic analgesia is a method of intravenous anesthesia which combines the use of a neuroleptic drug with an opioid analgesic drug. Such a combination produces a state which differs from the classical general anesthesia in that the subject is conscious and is able to cooperate during operative procedures. The most favorable combination in the clinical practice is that the neuroleptic droperidol and the analgesic fentanyl. Droperidol, it is a butyrophenol derivative. It's short acting, 2 to 3 hours, and more potent. It's a typical behavioral effect of calming. It has antiemetic effect and also has alpha adrenergic blocking actions. Fentanyl, it belongs to piperidines. It is a morphine-like opioid analgesic that is used exclusively as a supplementary analgesic in inducing general anesthesia. It suppresses the respiratory and cough centers. Fentanyl. It is 100 times more potent than the morphine. Fentanyl is 100 times more potent than morphine, but its action is of short duration. When given intramuscularly or intravenously, fentanyl about 2 to 20 micrograms per kg, it rapidly produces profound analgesia lasting for about 30 minutes. The fentanyl actions can be antagonized by giving naloxone. So droperidol 2.5 mg and fentanyl citrate 50 micrograms in 1 ml. Droperidol 2.5 mg and fentanyl citrate 50 microgram in 1 ml given intravenously cause complete analgesia and amnesia sufficient for surgical procedures without marked hypnosis. The major advantages of neuroleptic analgesia: smooth onset and rapid pro-anesthetic recovery. There is less danger of hypotension. There is suppression of vomiting and cough. Continued analysis in the post-operative period. Availability of patient's cooperation during the operative procedures such as eye, oral, orthopedic surgeries, angiocardiography, myelography, and bronchoscopy. Because the combination does not disturb the cardiovascular dynamics, neuroleptic analgesia is claimed to be very useful in old people and in the poor risk cases. The combination can be used to induce anesthesia, which can then be continued with the other general anesthetic agents such as nitrous oxide oxygen mixture and muscle relaxants. Adverse effects include hallucination, mental depression, extrapyramidal disturbances due to droperidol, and respiratory depression due to fentanyl. So general anesthesia for major surgery. For induction, we give IV anesthetics. For maintenance, inhaled anesthetics. Neuromuscular blockers for muscle relaxation. So neuroleptic analgesia with droperidol, combination of droperidol and fentanyl. Coming to the pre-anesthetic medication. Pre-anesthetic medication, the drugs used before the administration of an anesthetic agent with the object of making the anesthesia safer and more agreeable to the patient. The reasons for such medications: for sedation, to reduce the anxiety and apprehension without producing much drowsiness, to obtain an additive or synergistic effect so that the induction could be smooth and rapid and the dose of general anesthetic could be reduced, to counteract certain adverse effects of the anesthetic drug used such as salivation, bradycardia, and vomiting, to relieve pre and post-operative pain, to suppress respiratory secretions, and to reduce reflex excitability. Again, there is no single drug which can achieve all these objectives, and hence usually a combination of drugs is used. The drugs commonly used for pre-anesthetic medications: analgesics, antiemetics, antisecretory, sedatives. Atropine. Atropine inhibits heat loss by suppressing the perspiration. Anti-cytokine effects last for 4 hours. Increase the heart rate. So atropine 600 micrograms intramuscular is generally combined with morphine to block the vagal actions so as to reduce the salivary and respiratory secretions and to prevent parasympathetically induced reflex hypotension and bradycardia. It may thus lessen the possibility of cardiac arrhythmias during the induction stage. Because of the blockade of the cardiac vagal action, atropine may produce tachycardia. Now it's a synthetic analog. Glycopyrrolate is now preferred antimuscarinic agent because of its less central actions and less tendency to cause tachycardia. Atropine is contraindicated in obstructive uropathy, obstructive disease, GAT, myasthenia gravis, paralytic ileus, intestinal atony. crosses the blood-brain barrier and may cause confusion, post-operative somnolence, and delirium, particularly in children and elderly. The other drugs which are used in pre-anesthetic medication, they have antiemetics like promethazine and trimeperazine, which have antiemetic properties and may help to prevent the post-operative nausea and vomiting. Dose 25 to 50 mg deep intramuscular IV, 30 minutes prior to the anesthesia. If giving IV, promethazine has to be diluted in the normal saline. Contraindicated in patient with increased intraocular pressure and external obstruction. Anti-anxiety drugs to be given before surgery, that is in pre-anesthetic medication. Benzodiazepines, midazolam, diazepam, lorazepam are preferred because of their safety, muscle relaxant property, and less respiratory depression. They also produce amnesia. Diazepam in the dose of 5 to 20 mg has been widely used. The sedative hypnotics. Barbiturates, secobarbital 100 mg orally can be given. Opioid analgesics such as morphine, pethidine, buprenorphine. Morphine, the range of 10 to 15 mg intramuscular. Pethidine, 50 to 100 mg intramuscular. Buprenorphine, 300 micrograms intramuscular, are generally employed for their sedative and analgesic properties before major surgery. Buprenorphine has a longer duration of action. These opioid analgesics reduce the amount of general anesthetics required. Antiemetics, like metoclopramide, ondansetron, can be given in the pre-anesthetic medication. H2 receptor blockers like ranitidine, famotidine, and omeprazole. So the drugs are given in the pre-anesthetic medication for sedation, for additive or synergistic effect, to counteract certain adverse effects, to relieve pre and post-operative pain, to suppress the respiratory secretions. So some of the drugs administered during anesthesia are the skeletal muscle relaxants, such as succinylcholine, to achieve good muscle relaxation. A very short-acting ganglion blocking agent like trimethophan or sodium nitroprusside to produce controlled hypotension. Drugs are administered to counter the anesthetic complication like vasopressor agents like methoxamine or phenylephrine to correct the hypertension. So the general anesthetics, to compare between the nitrous oxide, and halogen. When we compare halogen with the nitrous oxide, halogen is a volatile liquid, whereas a nitrous oxide is a gaseous general anesthetic. Halogen induction and recovery are faster. A nitrous oxide induction and recovery are rapid because of low blood solubility. Nitrous oxide has a wide margin of safety than the halogen. Nitrous oxide produces excellent analgesia when compared to the halogen, which produces poor analgesia. Halogen is expensive, whereas nitrous oxide is cheap. Halogen produces hypotension, hepatotoxicity, hyperthermia, whereas nitrous oxide has second gas effect and diffusion hypoxia. So when we compare halogen with nitrous oxide, halogen is a volatile liquid, nitrous oxide is a gaseous general anesthetic. Rapid induction and recovery by nitrous oxide because of the low blood solubility. Wide margin of safety. Excellent analgesia. And cheap when compared to the halogen. Halogen produces adverse effects like hypotension, respiratory depression, hepatotoxicity, hyperthermia. Nitrous oxide produces second gas effect and diffusion hypoxia. The second gas effect, when nitrous oxide is given in higher concentration, that is 70% to 80%, with another potent inhalational anesthetic such as halogen, it facilitates the delivery of the halogen to blood at a higher rate and helps in achieving faster induction. This effect is termed as second gas effect. The nitrous oxide, when given in higher concentrations, that is 70% to 80%, with another potent inhalational anesthetics such as halogen, nitrous oxide facilitates the delivery of halogen into the blood at higher rates and helps in achieving the faster induction. This effect is termed as second gas effect. And when the nitrous oxide is discontinued, a large amount of nitrous oxide rapidly diffuses into the alveoli from the blood owing to its low solubility. This dilutes the alveolar air, causing a drop in the partial pressure of the oxygen in the alveoli. The gas also dilutes the alveolar carbon dioxide, causing a decreased diaphragm ventilation. During this time, breathing room air results in hypoxia, which is termed as diffusion hypoxia. So when the nitrous oxide is discontinued, a large amount of nitrous oxide rapidly diffuses into the alveoli from the blood owing to its low blood solubility. This dilutes the alveolar air, causing the drop in the partial pressure of the oxygen in the alveoli. So the breathing air results in hypoxia, which is termed as diffusion hypoxia. This diffusion hypoxia can be prevented by administration of 100% oxygen 5 to 10 minutes after discontinuing the nitrous oxide. So diffusion hypoxia can be treated by administration of 100% oxygen. So it's prevented. Diffusion of hypoxia can be prevented by giving 100% oxygen 5 to 10 minutes after discontinuing the nitrous oxide. So at the end of the session of the general anesthetics, maybe phase 2 medical should be able to differentiate, define the general anesthetics, to know about the pre-anesthetic medication, to know the mechanism of action, stages of anesthesia, classify the general anesthetics, and able to differentiate between nitrous oxide and halothane, able to give the complete picture of the general anesthetics regarding inhalational and parenteral general anesthetics. You should know about the balanced anesthesia, conscious sedation, pre-anesthetic medication. Thank you for active listening.